Well, thank you, Vinay, and thank you, colleague from IDL. Congratulations on Foundations Day, and congratulations for this festival of endoscopy. I really, really enjoyed and celebrate with all of you. The topic today is the future scope of metabolic endoscopy. This is a very large topic, so I'm just really going to focus on advancement and the future in detailing this topic. These are my disclosures. So first of all, just to highlight for 5 seconds or so the unmet need. This needs no introduction. The fact is almost a third of the world population is inflicted by obesity and its complications. And right now, 99% of the inflicted cohort have no effective therapeutic intervention to administer. So it's a hugely unmet need for humanity. It's also important to understand the pathophysiology of disease, and that's what's the basis for renaming this disease to be called as excess adiposity related chronic disease. And that's to highlight the important role of visceral fat in the pathophysiology of the disease. So visceral fat dysfunction results in a state of chronic inflammation in conjunction with a state of dysbiosis within the human gut, and leakiness results in breakdown of these inflamed fatty acids and dumping of these fatty acids into organs that are important for metabolic regulation, like the pancreas and liver, resulting in a state of low-grade chronic inflammation, insulin resistance, and the complications that we know are associated with the disease of obesity. So it's very important to highlight that. So when we talk about advances in metabolic endoscopy, I'm going to break them down into metabolic endoscopy diagnostics and therapeutics. So there's a lot we know about how we could use endoscopy to diagnose metabolically healthy versus unhealthy obese, because they're not equal. They both could share the same body mass index. They could both share the depot of subcutaneous fat, but visceral fat is a different story. And this is the key differentiator between metabolically healthy obese and metabolically unhealthy obese, as shown in this seminal paper published in GCI recently. And that's where endoscopic ultrasound could excel. And we have recently worked on this field to develop what we call the metabolic ultrasound station. So you could see the individuals could share the same body mass index. They could share the same protuberant abdomen and subcutaneous fat, but where they differ is in this deep depot of fat that drains directly to the portal circulation and gets inflamed and dumps these mediators of inflammation to the liver and pancreas, which is associated with the metabolic disease. And right now, this deep depot of fat is very hard to image and very hard to study physiologically, and it's very hard to sample because of its location. So that brings us to the first development, which is metabolic endoscopic ultrasound station, what I call it, the Bermuda Triangle of metabolic disease. And with endoscopic ultrasound, this is a station that we could easily and reliably find, and we always look at it when we look at the celiac artery, and all it takes is a slight clockwise torque toward the liver in that station, and you find access to this triangle that's defined by the celiac artery and the probe location. And this triangle is reflective of the depot of this deep visceral mesenteric fat. And here you could see the access to this area right there as a window to the metabolic health of the patient. Not only we could quantify this triangle, but also we could sample it for multiomics and lipidomics analysis to understand its contribution to human disease, as shown in this slide right here. So in this DDW, we will present in an oral presentation 155 patients where we measured the celiac artery mesenteric fat by endoscopic ultrasound and correlated to hard endpoints, as you could see here. This is the different metabolic complications associated with obesity and excess adiposity. And this is the measurement by EES of this metabolic triangle. This is versus BMI. The measurement of this metabolic triangle outperformed BMI in all these measures of fatty liver, metabolic syndrome, obstructive sleep apnea, hyperlipidemia, hypertriglyceridemia, hypertension, diabetes, and prediabetes, indicating it's a robust prognostic factor for metabolic disease, and especially important in cohorts where there's lipidomic or lipid dystrophy associated with early onset of metabolic disease, such as in Asian cohorts that we know. The second improvement is the ability to widely sample the liver for metabolic disease with endoscopic ultrasound. And here we show that we took enough sample using a core cutting needle in order to perform lipidomic analysis. And you could see the quantity of cells that we do. And now using this method, we could now classify the lipidomic profile of inflamed, unhealthy fat, both in the liver and from this metabolic triangle from the celiac axis as shown here, indicating that we could use endoscopic ultrasound to do prognosis for metabolically healthy versus unhealthy obesity in a way that no other technology could do. And this is now associating this lipidomic profile with histological endpoint like the NASH activity score and percent fat fraction on MRI. And you could see that there is a strong correlation between these measures and the lipidomic profile. Now, switching gear to metabolic endoscopy therapeutics. Again, this is a very rapidly evolving area with many randomized trials, more than any I could think about in the field of interventional endoscopy. And it's really augmenting or complementing the care of chronic metabolic disease as shown in the slide. I'm not going to belabor all these devices because I would like to focus on the future and advancement, but suffice to say, we have devices that target the stomach, and their main endpoint is to improve satiety, satiation, alter the accommodation and emptying of the stomach, to improve weight, to produce weight loss dependent improvement in insulin resistance. And there's devices that affect the small intestines that work on the gut mucosal barrier, gut microbiome, gut neurohormonal signaling with the central nervous system, with the end product that collectively these weight dependent and weight independent effects are improving insulin resistance, correcting the state of dysbiosis and leaky gut, and improving metabolic health. Here is the summary of all the data coming from randomized and non-randomized trials in this field for medical, surgical, and endoscopic treatment of metabolic disease. And you could see if we look at more than 10% total body weight loss at 1 year, which is the percentage of the cohort achieving that point, you could see that nicely these endoscopic options, whether implantable devices, gastric remodeling devices, are producing results better than medical treatments, and in par, some of them in par with some of the surgical treatments as well. So the first advancement in therapeutic metabolic endoscopy is gaining momentum, and that's where you want to see a field. A field will hit a dead block if it's not gaining momentums with payer, with government, and what have you. And this is a recent development that, based on work we've done with the intragastric balloon and the metabolic and histological improvement in patients with non-alcoholic fatty liver disease, the FDA issued a breakthrough designation of the balloon for the treatment of NASH. And the collective work from the global community and the US trials led to a Category 1 CPT code in the United States, paving the way for reliable reimbursement for these devices, which is it's a milestone to celebrate collectively as a field, because we know that there's a lot of technologies that have been there for 20 years without having this pathway to market. And now this is percolating into societal guidelines. This is going to come in gastroenterology soon, which is a consensus report about the role of intragastric balloon in the management of obesity and its metabolic complications. It's a very robust evidence-based manuscript that had technical review and review of the evidence to issue these clinical guidelines by the AGA. The second advancement of our field is to realize the benefits of intermittent fasting. This is recently published in the New England Journal of Medicine and shows the multiple metabolic adaptation to intermittent fasting. But the problem with intermittent fasting, it's hard to implement, because in one method, you need to be fasting for 20 hours and then eat for 4 hours, but patients find it hard to fast for 20 hours. And one of the development is the development of the full sense device, which we've been investigating with our colleagues at AIG, Dr. Kalapala and Dr. Reddy. And this device is agnostic to food. So this device is placed as an umbrella, as you can see laparoscopically here, exerting pressure in the cardia, activating these mechanical receptors to trick the central nervous system that the patient is full, and hence the name of a full sense device. Therefore, this, in my opinion, this device would be a nice, very nice, excellent complement to intermittent fasting, because a non-invasive anatomy-preserving device that exerts pressure, as you could see here on the cardia of the stomach, could result in adoption of a robust intermittent fasting program with all the metabolic benefit that comes with that program. Third advancement is in the field of gastric remodeling and endoscopic sleeve gastroplasty. This is a very rapidly evolving technique. When it first was introduced in the United States in 2013, you could see to now there's an exponential growth and interest. This is based on Google Trends in the number of searches for this procedure. And the reason is just appeals to patients. It's a procedure that preserves the anatomy, does not create a high pressure system, as you could see with this MRI that we do on these patients. You imbricate the greater curvature by tubularizing and shortening the stomach, but the function of the stomach is preserved. The innervations of the stomach is preserved. The complication the safety is excellent, and the tolerability of the procedure is excellent. So it's a procedure that highly appeals for patients, and thus far it's gaining significant momentum. So again, the theme of randomized trials continue with endoscopic sleeve gastroplasty. More than 20,000 cases performed, more than 2,000 of these published in the published literature. And now this will culminate in the conclusion of the multi-center randomized MERIT trial, which is involved surgical endoscopic centers and both academic and community centers in the United States. And this will hopefully be presented as a late-breaking abstract for DDW 2021. And it's a large trial, and I could tell you that the results are quite positive. So what's the advancement beyond the endoscopic sleeve gastroplasty in the space of gastric remodeling? Now we could use these tissue plications by a company called USGI to create a similar anatomic variation of the endoscopic sleeve gastroplasty using these very durable plications that have two nitinol baskets that to distribute the force. Each plication is about 7 centimeters. And if you place these plication in a synchronized fashion, starting from the level of the incisura, all the way to the proximal border of the stomach, you could see that you could tubularize the stomach and you could decrease its length, creating a similar physiology as endoscopic sleeve gastroplasty, but also with the potential added benefit of superb durability and easily scalability, because this really is a cookbook almost technique to follow with this procedure. Again, this is to highlight the point. This is the stomach before. This is stomach after. If you count the vertebral body, there's about 5 of them. That's the length of the stomach before. This is the length of the stomach after the endoscopic or after the post 2.0 procedure. You could see you shrink the stomach by 50% and you tubularize it along the greater curvature of the stomach. This is the endoscopic picture before, and this is the endoscopic picture after. And this is the endoscopic picture at 12 months, indicating the robust durability of this platform. Now we're going to have automated plication and suturing platform coming from a company called 90S in the very near future. This is still in early human trials, but we eagerly await this development as well. But what's tangible development in the field of gastroplasty is how to enhance the durability of this plication. We recently came with this technique that we use for both revisional and primary endoscopic sleeve gastroplasty, which is what we call enhanced gastroplasty or the kissing circle. Simply, we produce 3 EMR defects: anterior wall, greater curvature, and posterior. Then we introduced 60-watt APC at a 1 liter flow per minute in order to ablate the mucosa in between these EMR defects. And now we use, after that, we use the endoscopic suturing device to introduce U-shaped suture, just like traditional endoscopic sleeve gastroplasty technique. in order to have these circles kissing each other for enhanced durability. So you could see here, we're using the helix, and we're not going to suture inside of the AMR defects. That's dangerous. We suture to link these circles above. So the first bite happens above that area, and then we suture along the greater curvature, and then around the posterior wall, as we will see here. And then now here we're going to the greater curvature. And again, the important part is we are not suturing inside of the mucosal defects. We're suturing in the untreated area in between these plications. And now we're going to cinch it together. And what you can see when we cinch it together, it's the kissing circles. They come back nicely together. And here is the immediate results. As you could see here, you could see it's a nice tubular outlet with these three EMR defects approximating nicely each other. And this is really have introduced fantastic durability of this technique. You could see about a 3 centimeters outlet here after gastric bypass. And this is the patient that I showed you. This is 3 months after. You could see that there's a complete healing with a very robust bridging of these areas, creating about a 8 millimeters outlet compared to the previous one from before. The fourth advancement, which is a very important advancement, is in the role of the duodenum as the orchestrator of metabolic response. We know that the duodenum in states of metabolic disease becomes unhealthy, and there is a typical phenotypic changes that happen. There's a villus hypertrophy. There is crypt expansion from the proliferative zone. There's decrease in the stem cell niche, as you could see. There's a state of leakiness of enterocytes with dumping of mediators of inflammation to the portal circulation. There is a state of dysbiosis, and there is exaggeration of neuroendocrine signaling. So the question is, could we take this insulin-resistant state of duodenum and reset the metabolic clock to make it metabolically healthy and orchestrate a robust metabolic response? This has been the target of these barrier devices, but more recently, this has been the target of ablative techniques that could either use laser, heated water, or now athermal methods through the pulse electrical field in order to ablate the duodenum for metabolic benefit, just like we do with Barrett's esophagus, but now in the duodenum. And the biggest advance in this field is the use of athermal ablation or pulse electrical field, that if you introduce a high voltage concentrated electrical field, but only introduce it for nanoseconds, you're in this zone where you could create permeability in the cell wall and ablate a large wide structure without heat, which is a very disruptive technology for multiple areas in gastroenterology. This is based on a company in Minneapolis called Dayyeh that they introduced the benefit of pulse electrical field to hollow organs. And now you could ablate large, wide circumferential areas in the GI tract without the use of thermal ablation or energy, using this pulse electrical field. And you could see this is one of the experiments, and this is where we introduce it to half of the lumen. This is the unablated duodenum, and this is with one step on a pedal, you could ablate the entire duodenal surface with no heat delivery whatsoever. So the interesting part here is we know now if you ablate the duodenum, you have improvement in insulin resistance. But now if we reset the metabolic and the immunological and microbiome clock in the duodenum, there is evidence to suggest that the duodenum could be engineered to not only address insulin resistance, but to start making insulin as well, which is a fascinating area with multiple complications for type 1 and type 2 diabetes and multiple other diseases. But it goes beyond that. The benefit of pulse electrical field is because there's no energy. This field could be tailored to ablate mucosa, submucosa, and muscularis, which could ablate as an adjunct treatment for deeper muscular or submucosal invasion of tumors. But also it could be engineered to create a myotomy without surgery, right? Because it will ablate the muscular structure without interfering with the extracellular matrix. So you could see the advent of non-thermal ablation that could ablate the entire lumen could be applicable to multiple mucosal-based diseases like Barrett's, early cancer, NASH, you see ulcerative colitis, but also into muscular-based diseases like achalasia, gastroparesis, Hirschsprung, and what have you. Very exciting and very novel development in our field to introduce pulsed electrical field as a new athermal energy modality capable of doing lots of things in the GI space. So what's the future? The future is combination approaches with pharmacotherapy. We have now multiple effective devices targeting the stomach and small intestines. We also have multiple successful therapeutic agents like GLP-1 agonists. And now could we introduce them in sequence or together in order to have a paradigm for the chronic management of obesity? So repeatable devices, combinable devices, sequential devices based on understanding of the pathophysiology in osmosis. For using endoscopic ultrasound. This is a work in progress that we've been doing, where we created a device that would isolate the duodenum and block the forest. And this device will allow us to now benefit from this endoscopic GJ in order to introduce significant metabolic benefit by targeting gastric and small intestinal pathways. And finally, there's no lecture that talks about the future that is complete without the future of robotics. This is using in an ex vivo model, using a robotic system in order to create a wide margin endoscopic mucosal resection to enhance plication or gastroplasty techniques. You could see here with robotic, the ability to triangulate means that you could now do these very wide resection margins with ease and without difficulty. And now we have suturing platform that you could use them to approximate muscle against the muscle in order to enhance the durability of the techniques that we are all doing together. So with that, I would conclude with a quote from the founders of Mayo Clinic, Dr. William Mayo. I look through a half-open door into the future, full of interest, intriguing, beyond my powers to describe, and thank you for your kind attention.
So as usual, fantastic talk, Barham. I think there are a few which I haven't, what Barham has told and where are we at Indian level in terms of R&D or established techniques. First, coming to the balloons, as we all know, the Orbera balloon is the one which we all used of late till now, but now the new adjustable intragastric balloon is one thing which I look upon and then we regularly practice. One is because our stomachs are not as big as the Western stomachs. And so the tolerability of the balloon is not that easy. So once you have the adjustable balloon in hand, then probably you can increase or decrease the volume according to the need of the patient. So that's one thing from the balloons perspective, which we look forward. And then that will be one thing which is very handy in managing the patients of standalone obesity. Second, coming to the ingestible balloons without the endoscopy in the office. That is one thing which we look forward, but again, the efficacy of that is not as good as the regular balloons. And the third one, which Barham obviously showed on the work, what we are doing at AAG with Barham's help, is on the full sense device. And that is one thing which I'm looking forward as a futuristic thing, especially in a patient who has got standalone obesity, because that mechanoreceptor pressure exertion at the cardia will lead to early satiety. And it's a very simple way of deploying the device. Even the extraction of device also is very simple. And in fact, we have an experience of putting it max in 10 to 15 minutes, and then patient walks out in the evening, comes back after 6 months to retrieve it. And we have around 15 to 20% robust weight loss in this particular full sense device. The second part is about the gastric remodeling techniques, what he has touched upon, the ESG. So, well, we have fortunately hands-on experience with the Apollo overstitch, pose, as well as Endomina. And all of them have their merits and demerits, but I'm not going to talk on the comparison of this. But as of now, Apollo overstitch is the one which is dominating and which we have a good experience on. And that will be the one which the current generation endoscopists who want to pursue in the field of bariatric endoscopy have to be well versed. And coming to the the third part, which again is probably in India, that is one thing which fascinates me, the diabetes and obesity. Obviously, we are the diabetic capital of the world. And if anything has to be done, really, is to study upon the duodenum as the epicenter for metabolic control. And on this, the ablative techniques, what Barham has elicited, maybe thermal or non-thermal. And that is one area which we have to work on and then look forward. And we have a personal experience on the Metabolic Dayyeh, that is duodenal bypass liner, which has got a fantastic outcome in the first in animal experiments what we did. There's a little bit of migration issues which will be probably addressed in the next 6 months, and we are sure by 2022 around we are trying to get into the commercial market. So that's one easily deployable device, and then without any complications, which will address our people with diabetes. And as I told you, there is 1.5 to 2% decrease in the HbA1c levels in all these people having good glycemic index. The other one, which Barham has touched upon in the last few slides, is administration of this GLP-1 agonist, or the liraglutide or semaglutide. Barham, in fact, we are all waiting for the semaglutide oral form to come into Indian market. I believe it's there in the FDA approved recently, because in our Indian perspective, patients poking in every day subcutaneous injection is not that acceptable, which we have to do with liraglutide. We have to take every day for a couple of months together. So if the oral semaglutide, or rather the injectable semaglutide, comes in the Indian market, that is one add-on kid in the block, which will also help our patients to have weight loss, because once a week administered injection, or if it is a pill, even more, it will be fantastic. So that's one which we move forward. And just to put it in a nutshell, gastric remodeling and duodenal resurfacing by combination of gastric and duodenum is the one which we have to look forward in the future. And adding on this pharmacotherapy in the form of once a week GLP-1 analogs will make a big paradigm shift in people with standalone obese, standalone diabetic, obesity and diabetes. So I think that's what I wanted to tell from Indian perspective, what we are, where we are, and where we can look forward.